Hello, this is Dr. James Camp from Lee College in Baytown, Texas, and this is my lecture on putting it all together for cardiology, cardiac output. First of all, what is cardiac output? Cardiac output, which is usually abbreviated either as CO for cardiac output or Q, which is a standard sort of science abbreviation for flow rate. Cardiac output is the amount of blood pumped by the heart in 1 minute. It's expressed in liters per minute. And its normal range is about 4 to 8 liters per minute, depending on your body size and your exercise state. For extreme exercise, it can be up in the 20s. But a person at rest, as a general rule, at rest, your heart should pump your entire volume of blood, which is about 5 liters for the typical person, once each minute. So your cardiac output should be about 5 to 6 liters per minute for a healthy heart at rest. What it means, increased cardiac output substantially above 6 liters per minute is usually due to physiologic stress or metabolic demands, such as exercise. If a person is sitting down for a cardiac measurement after having just run to the cardiologist's office, they're going to have a higher CO. A high CO at rest can be symptomatic of a couple of things. If you have anemia or if you have a breathing problem, something wrong with your respiratory system, such that there's not enough oxygen in your blood, then you need to pump more blood, and so you're going to have a higher cardiac output. It's also indicative of hyperthyroidism. People with a high thyroid are going to overstimulate their heart, and it's going to beat a little bit. It's going to pump a little more blood than it normally should. Increased cardiac output, though, is usually not considered a life-threatening condition. Decreased cardiac output, substantially below 5 liters per minute, is much more of a cause for concern. You can have acute conditions that lead to low CO, such as a myocardial infarction, aka heart attack. If the heart is starting to die from lack of oxygen, then it's going to have a low cardiac output. Or it can be a chronic condition, such as congestive heart failure, where the heart muscle has weakened to the point where it can't physically pump enough blood to keep a high cardiac output. Or valvular heart disease, where the heart is working fine, but the valves are making it difficult to pump the blood through. So, if you had a stenotic valve, one that's resisting flow, or if you had a regurgitating valve, one that's allowing flow backwards in the wrong direction, either of those would cause the heart to have to work harder for a lower cardiac output. Any of these cases are potentially life-threatening because you could be not getting enough oxygen to your tissues because of the low rate of blood flow. Okay, so cardiac output depends on 2 factors. First, it depends on how fast the heart beats, aka, so CO depends on your heart rate, or HR, and it depends on how much blood the heart pumps in each heartbeat, your stroke volume, or SV. Those of you who've read ahead will know the relationship, but you can guess it fairly well from looking at what we're measuring. CO is volume per time, okay, liters per minute. HR is beats per time, okay, usually beats per minute. And stroke volume is volume per beat, okay, given usually in milliliters. Okay, so it would stand to make sense that if you took the number of if you took the volume for each beat and multiplied it by the number of beats per time, you would get the volume per time. Okay, so that is in fact the relationship we see. Cardiac output equals heart rate times stroke volume. Okay, so memorize this little relationship. That will come in handy. All right, so when we want to know the answer to the question, what determines cardiac output, the answers are heart rate and stroke volume. So what determines heart rate? The obvious answers are the pacemakers. Well, let's look at those. The SA node has an inherent rhythm of 100 beats per minute. This is interesting because if you think about it, your heart rate is almost never 100 beats per minute. If you're at rest, it's in the 60 to 80 range. If you're exercising, it's up in the 120 to 150 to 180 range. So how is it that the SA node isn't quite what determines our heart rate? The AV node, to make things even more interesting, has an inherent rhythm of 40 to 50 beats per minute. Much slower than the SA node, and actually too slow to really sustain anything but a resting metabolism. It's bradycardia. And the cardiac muscle alone, without a pacemaker, has 20 to 40 beat per minute heart rate, which is too low to really sustain life at all. So how do these three factors work together in such a way that we don't have multiple parts of the heart beating at different heart rates? One of the ways to imagine this is that you can think of the heart as a series of train cars all hooked together. If you have a series of train cars and there are multiple engines in the train, what would happen if the first engine was set to 100 miles per hour and the next engine was set to 50 miles per hour? Well, we wouldn't have two parts of the train running at different speeds. One of them would ultimately win. And what happens is that the SA node drives the heart at not 100 miles per hour, but 100 beats per minute. And that passes through the atria, and that passes to the AV node and overrides the AV node's inherent speed. And so the AV node is stimulated by the SA node at 100 beats per minute. And then that passes to the bundles and the Purkinje fibers and ultimately to the ventricles, and their inherent rate of 20 to 40 gets canceled out and they're stimulated at the same 100 beats per minute. Okay, so you can see how this works. The SA node sort of drives everything else, unless it doesn't. As long as the cars and engines are all connected, they all go at the speed of the set by the fastest engine. Okay, I don't know if that's how real trains work, but that's how the heart works. But what can you imagine happening that might slow a portion of the heart down? If the SA node becomes disconnected from the AV node, it would be as if we now had two different trains. The SA node in the atria would fly off at 100 beats per minute, and the AV node would then keep limping along at 40 to 50 beats per minute, at about half the rate of the SA node. This is what we call a heart block, okay? And what you'd see on the EKG is a P wave and another P wave and then a QRST, okay? And then another P wave and then another P wave and then a QRST, okay? So the heart would be running at a different rate than, or the bottom half of the heart would be running at a slower rate than the top half. So that explains how the heart is able to run at one speed instead of two or three different speeds. But why is our heart rate never actually 100 beats per minute? The answer brings us back to the sympathetic. Okay, so the heart rate is never actually 100 beats per minute because the nervous system, the central nervous system, is always interfering in some way or another. During most of the heartbeat, during most of your life when you're at rest, the parasympathetic nervous system, our sort of rest and digest nervous system, is in control. And it sends signals down the vagus nerve to the two pacemakers, the SA node and the AV node, and these both have the effect of decreasing heart rate. Okay, they slow the heart down by decreasing the number of signals per minute that the pacemaker nodes are able to produce. How do they do that? Remember, we had that pacemaker potential, and then we fire, and then we have another pacemaker potential, and then we fire. Well, if you modify the electrical signals, the electrical ability of the heart to have this pacemaker potential, you can slow it down quite a bit. And so now with the parasympathetic stimulation, it takes longer to reach threshold, and so we have fewer beats per minute. When the heart actually wants to, or when the body wants to increase the heart rate, we do the opposite. We send signals through the sympathetic nervous system, through the sympathetic trunk, and those signals come to the two pacemaker nodes, and they have the effect of increasing the heart rate. Okay, and again, that's by modifying that pacemaker potential. Now we open more channels so that we shoot up to threshold very quickly, and we have a much higher heart rate, a much higher number of signals sent from the nodes. We can affect the heart rate, we as human clinicians can affect the heart rate through things called chronotropic agents. The body releases some of these, such as beta adrenergic activators, such as norepinephrine itself, the ultimate adrenergic activator. But the thyroid hormone also increases heart rate. And we humans tend to take a lot of substances into our body that can increase heart rate artificially. Some of the more common ones are caffeine, nicotine, and cocaine. Okay, cocaine is not, I hope, a common chronotropic agent, but cocaine is listed on here because most people who overdose from cocaine, it's because it overstimulates the heart. Another one that adds on here, though, are stimulant medications, such as those given to children and adults for attention deficit disorder. I personally am a poster child for attention deficit disorder, so I sympathize. And my resting heart rate during the day when I'm on my Adderall is considerably higher than it is at other times of the day when the medication has worn off. Is that necessarily a problem? Not really. I mean, I'm never out of the normal range of heart rates, but it can be an issue that clinicians should take into account. If a person is inclined to a higher heart rate or a higher blood pressure to begin with, you might not want to give them a standard stimulant medication. Of course, they may self-medicate with caffeine then and have the same effect, so who knows. On the negative side, there are agents that decrease heart rate. Acetylcholine from the parasympathetic nervous system, we've already seen that obviously has the effect of decreasing the heart rate. But you can also block the beta adrenergic activators with something called a beta blocker. Okay, beta blockers are one of the more commonly prescribed medications by cardiologists these days. They're used to treat hypertension. They're sometimes used to treat arrhythmias or various other cardiac problems. But what they do is they block the effect of the sympathetic nervous system from speeding up the heart, which tends to slow the heart down and lower your blood pressure perhaps solve any arrhythmia problems that are caused by the heart trying to beat too fast. Okay, so that explains heart rate. Stroke volume is a little more complicated. Okay, so as you recall, cardiac output is stroke volume times heart rate. What affects stroke volume? What are the factors that affect stroke volume? The first factor is how much blood is coming into the heart in the first place. You can't pump blood if it isn't there. So the venous return, sometimes called the preload, is the amount of blood flowing into the heart from the veins. Okay, if you think about it, more blood coming into the heart means that the heart can pump more blood. So an increase in preload will increase stroke volume. The second factor is the force of contraction itself, the force with which the ventricular muscle cells contract, such that an increase in contraction force, well, again, if you reason this through, pushing harder on the blood is going to make more blood flow. So an increase in contraction force will increase stroke volume. Does everything increase stroke volume? Well, not exactly. There's also a factor called arterial resistance or afterload. This is how much pressure is needed to drive the blood out of the heart. Okay? And again, if you think about it, the more pressure it takes to drive blood out, the less blood is going to flow. The more resistance there is to flow, the less blood is going to flow. So an increase in afterload will tend to decrease stroke volume. Okay. We can increase stroke volume with inotropic agents. Examples, again, are beta adrenergic activators. The sympathetic nervous system not only stimulates the two pacemakers, it also directly stimulates the cardiac muscle of the ventricles. And so that increases the force of contraction, which, if you remember, force of contraction was one of the things that increases stroke volume. So if we increase force of contraction with a adrenergic activator, we can increase stroke volume. Thyroid hormone, once again, increases the heart rate and force. And then there are certain drugs, the most famous being digitalis, that are used to treat low cardiac output conditions, such as congestive heart failure. And this just has the effect of making the heart pump harder than it normally would. We can also have negative agents that decrease stroke volume if, for example, a person's cardiac output is too high. Excessive potassium or hydrogen ions are natural negative agents. In fact, too much potassium in your blood can kill you by shutting down the heart. Calcium channel blocker medications, on the other hand, are artificial agents that treat hypertension by decreasing how much calcium flows into the heart during its plateau phase. If there's less calcium, you're going to get less muscle contraction and so less force. So calcium channel blockers are used to treat hypertension in cases where the beta blockers haven't worked. They're considered a little more extreme than a beta blocker. Okay, so really quickly reviewing the three factors that affect stroke volume. Venous return, increased venous return, fills the heart with more blood, stretches the heart wall more, gives the heart the ability to pump the blood harder, and increases stroke volume. Inotropic agents increase calcium levels in the heart. Additional cross bridges form and the ventricles contract with greater force, and the stroke volume increases. Afterload, on the other hand, such as atherosclerosis, a deposition of plaque on the arteries, is going to narrow the arteries, make it increase the resistance to blood flow. More resistance means it's harder to pump blood into the arteries, and so stroke volume decreases. Okay, here's a handy little chart that shows you chronotropic agents feed into cardiac output through heart rate. Inotropic agents feed into cardiac output through stroke volume. And then you see how preload tends to increase and afterload tends to decrease the stroke volume. Okay, so I want to close this presentation with a little case study on cardiac output. You're working in a cardiologist's office and a patient comes and complains that they feel sluggish and low energy all the time. You measure the patient's resting heart rate at 65 beats per minute. That's a little low, but it's not low enough to count as bradycardia, so you don't suppose that there's anything wrong with the patient's heart rate. The doctor then orders a Doppler echocardiogram, which indicates that the stroke volume is 55 milliliters per beat. Is that good? Is that bad? It's hard to tell without being able to calculate the cardiac output. So we need to calculate the cardiac output. We need the stroke volume. We need the heart rate in beats per minute. We need the stroke volume in milliliters per beat. And then we need to correct for the fact that the stroke volume is in milliliters, but we want the cardiac output in liters, so we divide by 1,000. Now take a minute here and see if you can do this calculation for yourself. Pause the video and do the calculation and then come back and see if you got it right. Okay, so the heart rate was 65 beats per minute. Okay, the stroke volume was 55 mils per beat. So if you put into your calculator 65 times 55 divided by 1,000, you should come up with the number 3.6 or so for liters per minute. Now, you recall the normal range for cardiac output is between 4 to 8 liters per minute, depending on size of the individual. Assuming this is an average-sized individual, they probably should have a cardiac output close to 5. So 5 to 6. So 3.6 is really quite low, in my opinion, and does indicate some sort of a problem. So what could be causing this? I want you to take a minute, again, pause the video and see if you can think of a couple of conditions that could be causing low cardiac output in this patient's case, and a couple of treatments that would help the patient in the case of each of those diagnoses. All right, well, here are my 3 answers. The condition could be, the most obvious problem is the stroke volume. It could be caused by a problem with the force of the contraction, that the heart muscle, the patient's heart muscle could be weakened. Maybe they had a silent heart attack at some point and nobody knew, but they may have a weak heart muscle. So you could give them a medication such as digitalis and positive inotropic agent to boost their contraction force. It could be that the patient has trouble increasing their heart rate enough. Now you say, wait a minute, 65 beats per minute is in the normal range. It is, but it's not in the normal range for someone who has a stroke volume of 55 mils per beat. So their heart should be increasing its heart rate to 75 or so to compensate. Maybe we need to give the patient a positive chronotropic agent to help boost their heart rate a little bit. We'd have to do a stress test and see if the patient's heart rate was able to increase during periods of exercise or not. And then finally, the problem could be that the heart is pumping perfectly hard to push the blood through the heart, but that the valves are not cooperating. The patient could be suffering from valvular heart disease. If that's the case, you would need to do some more echocardiogram work to try to see if you could find the valve that was not cooperating, and you might need to do some sort of surgery to repair or replace that heart valve. Okay, those are 3 examples. You probably could come up with several more. So now you know how to use cardiac output as a diagnostic tool, you know how to calculate cardiac output, and you know some of the factors that play into it. Finally, just to show you how cardiac output changes with activity, this is a picture of an athlete at rest with a normal 5-liter cardiac output, and the same athlete during strenuous exercise showing over 3 times the cardiac output. So that's just important to show you that that these things do change a bit with exercise. All right, well, thank you for watching this video. I hope you enjoyed it and learned a lot, and have a good day.